everyone, welcome back. Today we're going to be talking about pain control, inflammation, and fever. We're going to kind of wrap these three concepts together because sometimes you don't get one without the other, especially pain control and inflammation. Those really do go hand in hand. We're going to take a brief look at your objectives next. These are the objectives for the pain, objectives for the inflammation and for the fever, and then let's launch. All right, let's launch into where does pain come from. So when we think about pain, we kind of have to think about like, how does it get from like here to my brain to make me actually do this? Because these two are tied together, but there's like a relay system going on. So one of the things we have to think about is we have to know what a nociceptor is. A nociceptor is on your skin, and it are pain receptors that are in your periphery that actually help to relay the information up to your brain that says, hey, you're having pain. Now, you have different types of fibers in your body that carry different pain responses to your brain in different ways. So for instance, like your A delta fibers, they're unmyelinated, or sorry, they're thin and they're myelinated, which means that they send impulses a lot more faster than an unmyelinated fiber, sorry. And then a C fiber is tends to be unmyelinated, and they carry impulses very slowly through your body. Then you have this other stuff, it's called substance P. It's a neurotransmitter that's found in the brain that actually tells the brain, hey, this person is actually having pain, and it kind of transmits that through the brain. So understanding kind of like this process works with the nociceptors on the outside and how it runs through your periphery from your, like the point of ouch all the way up, helps you to understand how pain occurs. Okay, so nociceptors, understanding, is this like a sharp pain? Is this kind of a dull pain? Where's this pain at? Can't really pinpoint it. These all help us to understand kind of what receptors are being targeted whenever the patient is experiencing pain, and then that way we can help to treat them a little bit better. So nociceptor pain comes in two different flavors. It comes in a somatic and a visceral. And I want you to go to your book or to the World Wide Web and figure out what those are. Versus neuropathic pain, which is actually damage to the actual physical nerves. So based upon these two descriptions of nociceptor pain versus neuropathic pain, which type of pain do you think responds better to like conventional pain medications? So I will tell you that there is a difference. So I want you to think about it and look it up and figure out which one's it's going to be easier to treat, the nociceptor pain versus the neuropathic pain. So when we think about pain, we classify pain into one of two things. We say someone's having an acute episode of pain, or maybe it's a chronic episode of pain. So the acute episode of pain, it can be very intense, it happens, and then once the tissue repairs itself, it's over with. Versus this chronic pain that just happens over and over again, and it's just persistent. And usually we say that if it has happened for more than 6 months or it's starting to affect their activities of daily living, that this patient would be considered to have chronic pain. Now, I know what you're thinking to yourself. Okay, look, acute pain, I totally understand. But like, is this patient got like, I don't know, like a chronic, like someone stabbing them in the foot all the time? Like, how do you get chronic pain? Well, the reason why we get chronic pain is because we get chronic inflammation. So if we were to look at the cellular debris field that is going on inside of a body, it might look something like the next slide. This is probably what it would look like from a cellular perspective for someone who's got chronic pain. It kind of looks like a war zone. There's just debris everywhere. There's all this stuff going on. You have all these inflammatory guys that are all running in and running out, and they're trying to repair everything. Chronic inflammation, chronic pain, is normally caused by chronic inflammation. That's the reason why we really wanted to marry these two concepts for you guys, the concept of pain and the concept of inflammation, because they really go hand in hand. Even with an acute episode of pain, you're going to have some inflammation. That's how your body is made. So let's dig a little bit further into that and talk a little bit more about inflammation and how it affects pain levels. When we talk about inflammation, we talk about these guys in our immune system that are on site in order to help to clear things up or to make things happen. So again, like I told you, an inflammatory response is not an evil response, okay? It's just that sometimes our body goes a little cray-cray, and then we have to figure out how to start that immune system off. But let's say, for instance, that I get a cut on my arm. I want this immune system to happen. I need my blood vessels to dilate. I need fluid rushing to the area. I need white blood cells and all these guys to come in and start to begin to repair that wound, okay? The same thing happens in a microscopic level if I get bronchitis or an acute sinusitis. All of a sudden there's a pathogen that shouldn't be there. I need this inflammatory response in order to jump in, save the day. But like I said, sometimes, especially with our patients who are experiencing chronic inflammation, those patients' inflammatory responses don't shut off ever. And because of that, we have constant inflammation. Constant inflammation leads to pain. So when we talk about inflammation, just like when we talk about pain, we can have acute inflammation that's onset immediately, lasts 8 to 10 days, then it goes away. But then there's this other type of inflammation, this chronic inflammation. And I feel like chronic inflammation and chronic pain can both kind of be described with the same analogy. You know, you put a lobster in a cool pot to cook it, all right, and you gradually turn the temperature up and up and up so it doesn't realize that it's cooking. So the same thing happens with inflammation and chronic inflammation. Inflammation doesn't start off being, sometimes it doesn't always start off as being hugely bad, but sometimes it's just little by little, and then all of a sudden it's all the time and it's creating all this havoc. So we do have patients with chronic inflammation that they're stable for a long time and then they have a flare and then they go back and they have a flare and they go back to their baseline. We do have that with inflammation, but for the most part, I think about these patients that have inflammation that don't even know about it. So, you know, the first picture here on the slide, you can obviously tell that there's an inflammatory process going on. It's red, it's ruddy, it's wrong, we have a site of infection. I'm thinking cellulitis. But the pretty girl at the bottom, we may not recognize that she's got inflammation going on because we don't have these overt symptoms of inflammatory process going on. We may see other things, but sometimes you really have to dig on these patients with inflammation in order to determine what their symptoms actually are, especially with chronic. So remember, inflammation is a sign of a chronic underlying disease process. I think you're going to be surprised to know that a lot of the common diseases that we battle in healthcare have a chronic inflammatory disease process to them. Obesity, diabetes, gingivitis, these are all signs and these are all diseases that have a chronic inflammatory disease component to them. So if I see these diseases come up on my past medical history, I'm thinking inflammation. There's inflammation going on in their body. So when we have inflammation, we typically have pain. So with these patients, I start looking for chronic pain in them and asking them about, you know, is there anything that prevents you from doing the things that you want to do? Now it's always within reason. If you are a 95-year-old person and you haven't ridden horses in 25 years, you're probably not going to be able to start that today, okay? But if you were able to ride a horse 6 months ago and now you're not, and the reason is because of pain, then I need to know that so that we can help you get back to what you want to do in your life. Okay, so I think you figured it out. Pain and inflammation, they go together. And now you're probably wanting to know what in the heck do we do to actually manage it? Well, I think as the conversation has gone, I'm hoping that you understand that like acute inflammation, boom, we got a really clear-cut idea about how we need to take care of that. Acute pain, acute inflammation, boom, bada bing, bada boom, we're done. Chronic inflammation is a lot more complicated. I feel like in the last 5 to 10 years, we've done a lot of research, especially in healthcare and research labs, in order to discover more about chronic pain, more about inflammation. I think people set out to discover huge things. Like they were like, you know what, I'm going to go out and I'm going to discover what is the cause of ulcerative colitis. And it came back down and the simple answer was inflammation. They're like, okay. All right, look, now we're going to go decide what is the problem with arthritis. And it comes down to inflammation. So many of the chronic diseases that we come down to, it really boils down to a problem with inflammation. Even diabetes comes down to a problem with inflammation. So once we start to understand the chronic disease process that we're treating and get the chronic disease under control, the inflammation gets better, which means that the pain gets better. Okay, so like I said, acute inflammation, acute pain, it's a little less complicated. Chronic inflammation, chronic pain can be really complicated, and it really takes a team of healthcare professionals listening to all these people and to talk about how we need to best take care of them. So as always, when we talk about taking care of patients, I would like to tell you that, oh, this is a list and this is just for acute pain management or acute inflammation. But this is a pretty good list for patients, no matter what their inflammation, no matter what their pain is. If they're having back pain, I can rationalize that any of this medication, non-pharmacological treatments would be helpful. If they're having knee pain, I can still rationalize that this is a realistic list. Because typically people complain of the musculoskeletal type pain. So this would be a good way to kind of just say, hey, so I hear you're having some pain. How about you go rest? Would you like an ice bag for that? Let's compress, put on something like a compression stocking or a compression device. Let's elevate it. Let's rest for the next 2 days and see how it goes. TENS units are amazing. And then of course we have a lot of over-the-counter stuff like topical agents like Bengay, Aspercreme, Salonpas. They all have their heating agents to help to relieve some of the pain. There's a few more non-pharmacological treatments that we can try. Again, I always tell people, I'm like, we're going to start with non-pharmacological first, see how it works, and we can kind of see how it goes. Now, I'll tell you, typically in hospitals, what we do is we'll do a little non-pharmacological and a little medication, and that way we're kind of overlapping the two. Okay, and we say, like, how did this warm blanket make you feel? How did this ice pack help you? Can I massage that for you? You can do things like that to help to take away the pain immediately while you're waiting for those pharmacological agents to kind of get in there. Maybe some other ideas about ways to treat pain here, everything from acupuncture to chiropractic. Please feel free to Google any one of these. I feel like one of my favorite ones on here is cupping. We had a lady in the office just the other day, and her neck was bothering her. She was at her massage therapist, and so he cupped her neck. The only problem is that after he cupped her neck, it looked like she'd been like hickeyed up. So you may want to not cup your neck, unless you'd like that kind of stuff. The other stuff on here: meditation, relaxation, art, music, therapy, hypnosis. Those are coping strategies on how to deal with pain. If we give patients the ability to make sure that they understand how they're going to deal with this illness, how they're going to deal with something, then you can get them a lot of help in order just to cope with things as they move forward. Now, there's lots of different reasons and things that are going to affect your ability to help a patient manage their pain. So the patient's age. Smaller children, older adults, those kind of patients can get complicated. And the reason I say that they can get complicated is because sometimes they don't have the ability to rationalize or reason. And so they're just in pain and they want to cry about it, but crying doesn't help and you're trying to get everything better. So it can just be complicated with ages. Then the other thing to think about is the patient's attitude. If the patient has a very negative attitude to everything you're asking them to do, it can be very complicated in order to get their pain under control. They're like, that didn't work the last time. I'm not doing it this time. So their attitude has a lot to do with them. Their level of tolerance. If you have a patient who's been on a medication for a long time and all of a sudden they're no longer able to get that medicine, and we're having that frequently in our community right now, they aren't able to get their hydrocodone anymore because it went to a different schedule of medication class. And so because of that, their tolerance level to pain medication is pretty high. If you gave me their same dosage of medication, then I would probably be under the table and absolutely appalled. Sorry. Level of compliance. Sometimes the level of compliance with a patient can make a huge difference into how well their pain is controlled. If they will do the routine medications that we ask them to do, it will give us better pain management, and we won't have to use the PRN stuff, the stuff that they're not going to take as frequently or for breakthrough pain as much. Okay? Developing coping skills for patients who have chronic pain is a huge deal. We need them to have a plan. Okay, we need them to understand that, yes, we understand that you're in pain. Yes, I believe that you're in pain. And then help me to understand where you want to be here, and let's get you some coping skills. Meditation, relaxation, yoga, taking time for themselves, exercise. There's a whole ramification there if they don't have good coping skills. Also, cost. So we have some great pain medications. We have some great pain management plans, except that not everyone has healthcare insurance and not everyone is able to afford the really great medicines. So we've got to do what do we have available? What will their insurance, what can they afford? And what can we do to help mitigate them from trying to use illegal substances? Support. You have to have compassionate family members in order to deal with patients who are on long-term chronic pain management therapy. Okay, got to have a good support system. Otherwise, we're kind of spinning our wheels a little bit. So the other thing that we need to think about, or actually as we're going forward here, here's a list of all of the different flavors of medications that we can choose for patients in order to treat them for pain. There's some on here that are some pretty non-traditional forms, like the cardiac medicines. The cardiac medicines, I just want to put in a brief plug for them. This would really be used by a pain specialist. We wouldn't see these quite as frequently like in a primary care's office. But I wanted to point them out to you because I think we as nurses get into this habit of, oh, well, you're on clonidine, so you must have high blood pressure. And so I just write down high blood pressure. And the patient's like, no, I don't have high blood pressure. I have chronic pain. Okay, so I need to think about that. Those other two cardiac medicines on there, the first one, the milexitine, is not seen very often in practice, but you will see a flecainide in practice. Typically, we give that one for an irregular heartbeat. So if you saw that one, you might just assume, oh, well, they've got an arrhythmia. And you can be telling a fib because they ain't got no arrhythmia, they're using it for chronic pain. Again, they'll probably come from a pain specialist, not so much in the primary care world. So what I want to try to do with you is I want to kind of like walk through this kind of the way that we would see it in practice, the way that you most likely would start treating even yourself for pain if you had it. So our first step is going to be our non-NSAIDs. So our non-NSAIDs, they only have one in the class. Woohoo! One drug to learn. It's good old-fashioned acetaminophen, also goes by the brand name Tylenol. It is both an analgesic and an antipyretic. Works fantastic to help take away pain. Also, it's great to help to control fever. So with these patients, it is metabolized out by the liver. So you can get some patients who are heavy drinkers or take medications that are like anticoagulants, like warfarin, that shouldn't remix the Tylenol and the aspirin and the acetaminophen, Tylenol and acetaminophen together. With kiddos, with adults, we usually say that we don't want you to have more than 3.5 grams a day. And then for kids, we actually have to do a little bit of a dosage calculation in order to get their starting doses. So typically, manufacturers in the hospital will allow us to give a child more Tylenol per kilogram for the first dose, but then after that, we drop down to a lower dose of Tylenol for them for every dose thereafter. We don't always go with the higher dose for kids on their fevers. It's just some preferences. So you'll have to check with your hospital policy to see actually what they want them to do. Always be sure that when we're dosing children that we use the appropriate device. We want to make sure that we're leaving the kitchen spoons in the kitchen, okay? Need a dosing syringe or a dosing cup. That way we make sure that we're getting a consistent measurement. So with Tylenol, acetaminophen, we can get a lot of hidden places can have acetaminophen in that. So I'm going to talk to you about a man. This man's kind of near and dear to my heart. And I'll tell you what he did one day. So has some aches and pains because we're a little older and we got gray in our hair. So he took two of them arthritis, Tylenol arthritis this morning, okay? All right, and he's gonna take another 2 tonight because that's what he does to help control his chronic pain. And then, he wasn't feeling very good, he's kind of stuffy, so he took a cold and sinus, and there was another 500 milligrams of acetaminophen in that, and he took 2 tabs of that. And then, about 3 o'clock, back started hurting after working in a hole all day. And then we decided we'd take some non-aspirin pain relief, okay? And then finally, couldn't sleep last night, so we took Tylenol PM, which had another 325 milligrams of Tylenol in that. Now, I don't know if you've been carrying along with the story or not, but if you'll add all that up, there's a lot of Tylenol there, okay? And I'll tell you, he's over his dosages. So very important that we teach our patients to recognize the generic name of Tylenol as being acetaminophen, because whenever the jar doesn't say that this is Tylenol, and we tell them like no more than 3.5 grams in a single day, they're like, oh, no problem, no problem. Except that when we go to the pharmacy and we start looking around and this product has Tylenol in it and this product has Tylenol in it, so they have like these hidden doses of Tylenol in them. So you want to be sure that you're explaining to your patients what acetaminophen is and to look for it in combination products. I typically recommend to my patients, I'm like, look, don't buy a combination product because you don't actually know what drug in there actually worked for you. So you may just buy those products separately. That way you can take them. It may mean they have to swallow more pills, but it also helps to prevent them from doing this. Oh, I forgot to tell you. Also got up in the middle of the night and took some hydrocodone because he's having a really, really bad backache. There you go. Now he's really overdosed. NSAIDs. So NSAIDs are our non-steroidal anti-inflammatory drugs. They come in a first generation and a second generation. The cool things about these drugs is that they are anti-inflammatory, antipyretic, and of course they're also an analgesic. I will tell you that I listed all the NSAIDs that I possibly know about that I've seen in town. The reason I did that is because one NSAID may work for one patient better than another one. So like I've had patients who are like, oh my gosh, ibuprofen, that's the way to go. And then I have some that are like, ibuprofen? No, I only like Aleve. Okay, whatever works for them, okay? Both ibuprofen and naproxen come in a prescription strength. So typically if the provider can write a prescription for it, or you can purchase it over the counter. Ketorolac, meloxicam, indomethacin, diclofenac, they all have to have a prescription. And then of course, siloxybib does too. Let's talk a little bit about the patho of how the NSAIDs actually work. Okay, so you get an injury to the tissue. You have this stuff called hydronic acid. It gets squirted out. And then you've got COX-1 and COX-2 that are being activated. So whenever COX-1 is activated, what it does is it has like this cytoprotective kind of an effect. It's really helpful because it helps to protect your gastrointestinal system from ulcerations. It helps to keep your platelets where they're not too sticky, but they're just right sticky. It helps to provide some renal protection so we don't kill off your kidneys. It causes vasodilation and bronchodilation. So really and truly, we want to keep all that good stuff. Like that is good. We want that to go on. Well, our non-selective NSAIDs actually block COX-1 and COX-2, okay? So COX-2, what it does is it's really got the nasty undesirable effects that we really don't want. It causes inflammation, pain, fever, and decreased platelet aggregation. So if we could keep one of these guys active, it would really be the COX-2 guys. Like we'd really want them guys to continue to work but just not have the pain part. So I've got my arrows kind of backwards here, okay? So the non-selective NSAIDs, they block both the COX-1 and the COX-2, but the COX-2 just blocks the COX-2 and allows this action to continue, but allows the COX-1 to continue its action. So with NSAIDs, they're blocking both a COX-1 and a COX-2, so we get some undesirable effects because we're blocking both pathways, versus the COX-2, which is just blocking the bad stuff that we don't want. We really thought these medications, when the COX-2s came out, that they were going to be life-changing, life-altering, that it was really going to happen, that this is it. We were going to leave behind these silly NSAIDs that we'd had on the market forever, and they were going to be amazing. And then we found out that even though we had a COX-2 drug that was COX-2 specific, that we still got almost the exact same side effects of an NSAID as we did with an NSAID that blocks COX-1 and COX-2. We got the exact same side effects. So we didn't get the much bang for our buck as we thought we were going to. However, they do work a little bit better to help to do some of this stuff, but they still have some of the same problems as a first generation NSAID. Like I said, we thought we were leaving all that behind. We thought we were going to leave gastric irritation. We thought we were going to leave all the platelet aggregation problems, the renal impairment. We thought we were going to leave all that behind. We didn't. So Sometimes our COX-2 inhibitors are not as great as we thought they were, but it's okay. We still have one to choose from. And for people who take it, who it works for them, we keep giving it to them as long as the renal system holds up and they don't have any bleeding issues. So our salicylates, also known as aspirin, again, you have to look at products to determine what has a salicylate in it. So America got really scared about salicylates in the 90s, or in the late 80s. That's whenever something came out called Ray's syndrome. So prior to the 1980s, if we as children got fever, we were actually given salicylates for temperature control, and it worked really well. The problem I found is that children, if they had a viral illness and took aspirin, could develop Ray's syndrome, and they would die from it. So there's a little YouTube video here. You can click on that and see what it looks like. Typically with salicylates, we see them not used as much anymore for pain control, but we will see them quite frequently given to most of our patients for prevention for its antiplatelet effects. So a stroke, an MI, angina, those types of effects, we tend to see that medicine a lot. Given a low dose, we like it to be enteric coated. That way it'll go into the stomach and not really break open there, but wait till it gets to the small intestine, and then the coating will dissolve and the medicine will go out into the system. So important that we understand how the medication works. There's a PO version and a PR version. Again, you have to watch for this medicine to be hidden. So Excedrin migraine actually has aspirin in it. So you want to be careful, like you would want to give that Excedrin to any child because of the aspirin in it. And just FYI, all Excedrin has aspirin in it. So, there was a big deal a couple of years ago about, Excedrin migraine, it works so much better. And they repackaged the original Excedrin and just called it Excedrin migraine. It didn't change. The formula for Excedrin has been the same forever. It's Tylenol and aspirin and caffeine. It's what it's been forever. But they got an FDA clearance to say that it worked really well in a clinical trial for the treatment of migraine, so they repackaged the box. So just be careful, okay? Make sure that you're reading the labels on these combination products so that you know exactly what's in there. So one day was a nurse in the ER, and I take over a report from the charge nurse. She said, yeah, take that patient in 5. He's been here all night long. He's here. We're observing him. Don't really. We're watching for a couple hours, and we're gonna send him home. I'm like, okay. So I go in, young guy, and I touch him, and he's wringing wet. And I'm like, hey, how you doing? He goes, what? I can't hear you. My ears are ringing terribly. And I'm like, they are? Why? He goes, I don't know. I said, do they always ring? No. Okay. So then there were some other things about his story. It just wasn't clicking out. He was getting very tachycardic on the monitor. He was still had a normal blood pressure, so I couldn't figure it out. Called the family. Come to find out his family and him, they'd been estranged for a while. They had been at Walmart the night before. The girlfriend had dumped him. He purchased some medicine for a headache, some aspirin for a headache. And when I asked his mom, I said, well, how full was the bottle? Because I have the bottle here with me now. She goes, oh, it was a brand new bottle. And there was 4 pills left in the bottle. So that got us to thinking that maybe, not thinking, no, we knew at that point that, yeah, he had overdosed on the aspirin. So again, be careful with patients, listen to them, listen to what they're saying, listen to what they're not saying, and always do your assessment on your patient. Again, it was kind of a weird case. I don't know if I've ever seen aspirin poisoning, but hey, first time for everything. So typically, I told you, you never give aspirin to kids. You got to love it in nursing school, and you're going to find a lot of this, is that there's always an except rule. You never give children aspirin except in the case of a child who's been diagnosed with Kawasaki's disease. Kawasaki's disease is an autoimmune disease. It's like an infection. It's kind of a viral thing. And with these children, because of the vasculitis that they experience, what they do is they administer a lot of acetaminophen to them. So again, had a kid. My nursing professors told me I would never see Kawasaki's disease. Well, they were wrong. I've seen it twice. So the first kid that I ever saw was a kid in Memorial Francis in Herman. It looked just like this little boy, bloodshot eyes, cherry red tongue, everything, high fevers. And we were giving a bunch of I can't even say it. I've been trained, so trained not to say it. A bunch of acetaminophen too at one time. The second kid I experienced, they had just gotten home from Texas Children's, diagnosed with Kawasaki's disease, African American child. So literally the only thing he had was like the red eyes. But it came time. He was in the emergency department getting evaluated for something. It was time for his dose of aspirin. Oh my gosh, I can't say it. Of aspirin, and he needed 8 chewable tabs to make the dose right. If you don't think that I didn't dosage calculation check that not once, but twice, but 3 times, I sure did. I checked that a bunch. So again, aspirin has great inflammatory properties. It has great antipyretic properties. It has great anti-pyretic properties as well. So the other medication that we need to talk about, and that would be our ibuprofen. Ibuprofen is a little confusing to some patients because it has more than one name. It has Motrin, and it also has Advil. So I always tell my patients, look, drugs are just like bologna. My bologna has a first name. It's OSCAR, but at the end of the day, it's still bologna, okay? So ibuprofen is the exact same way. Ibuprofen is ibuprofen, but its name is Motrin or Advil. Again, combination products, you got to be careful with this. You got to make sure that you're reading the back of the boxes, teaching the patients that this is ibuprofen. With this medication, we do see less gastric bleeding and platelet aggregation than with aspirin per se, but more than what we would see with the COX-2 inhibitor. We can use this one with some other anticoagulants, but you got to be careful. The higher the dose of ibuprofen goes, the higher that the anticoagulant is going to be affected. So for an occasional, oh, I have a headache, or oh, I bumped this, that, fine. But for someone who needs to take like 800 milligrams of ibuprofen for a couple of days and they're on an anticoagulant, we really have to consider that. We're like, whoa, hang on, let me talk to the doctor, okay? If this patient's got renal impairment, we want to know so that, again, one of those medicines is going to be processed through the renal system. And if we're not careful, then we can really cause some problems with the patient being able to process the drug out. Another one of our favorite drugs here, naproxen sodium, also known goes by the brand name Aleve. The great thing about this drug, it's got a really long half-life, which means that you can decrease the amount of dosings that you have to do. So typically we have the patient take 2 pills in the morning, 2 pills at night, works fantastic. It can be better tolerated than some of the other NSAIDs. Again, it can be really great too for teens with dysmenorrhea. The kicker here is that in order to treat dysmenorrhea, the painful cramps, is you really need to start this 2 to 3 days before the onset of their menses so that you can get the inflammation under control so they don't have that pain. Another medicine on our top 10 list here for as an NSAID would be the ketorolac. We give this one for very short durations, usually less than 5 days. This one's pretty notorious. It is prescription only. It is notorious for causing gastric irritation, gastric bleeding. So again, we don't want to do this for a very long time. The other thing I want you to know is I want you to pay real close attention if you're given this medication. I need you to look at the vial that you're giving. So a couple of years ago, we had 60 milligram vials and we had 30 milligram vials. The 60 milligram vial said for IM dose only, and the 30 milligram vial said for IM or IV. I don't know why. Okay, I just know that you have to follow what the bottle says. So make sure you pay attention to the physical vial when you get a dose of Toradol or ketorolac, that you're looking at it to make sure that it says for IV or IM usage. Okay, so Celebrex here. I got my slides out of order. That's the problem. Okay, so second, Celebrex over here, again, just kind of briefly review here that it blocks the pain while preserving the stomach and the platelet functions. Except that we know that it can also cause renal impairment and long-term use can give GI ulcers. So maybe it's not as good as we thought it was. The other thing is to think about with Siloxybib, it has a chemical component that is similar to sulfa. So if a patient has a sulfa allergy, the second generation Siloxybib, Celebrex would not be a medication that they would be able to take. Our big, huge medication here, that class for someone who's got really bad inflammation would be a corticosteroid. So corticosteroids come in a couple of different flavors: prednisone, dexamethasone, methylprednisolone, hydrocortisone, betamethasone. Do you notice that they all have one thing in common? I know, right? One thing. So this medication is amazing because it helps to decrease inflammation. The problem that you have is that if you give it long term, it suppresses the adrenal glands, and the adrenal glands get real lazy and they don't want to do what they're supposed to do. The other thing that the corticosteroids will do is if you have a patient who has a little bit of glucose intolerance, it'll raise up their sugars. It'll raise up everyone's sugars, but it'll really affect your diabetic patients. Because this medication kind of suppresses your immune system, you may not get the same response from the immune system if you need it. So say you have someone on a corticosteroid, and because you have them on a corticosteroid, let's say they have a wound. Well, that wound may or may not make pus and get red if you have the immune system on vacation. So, and very important that if we're going to give someone, if patients are going to be receiving this medication, that they understand that they need to be very cautious about washing their hands, staying away from large crowds, and they just need to kind of chill out while they're on the medicine. This medicine can also cause some pretty specific side effects. I will tell you that I can walk to Walmart or go and sit at the mall, and I can be like, they got some sort of a corticosteroid issue, like they're either taking the drug or they're like got hypothyroidism or something, okay, because they have a certain look to them, and I'll show it to you in a second. With this medication, sometimes what we'll do is we'll pop them with a big, huge loading dose, and then we taper them back down again. We never want to stop this drug cold turkey because, again, the adrenal gland can get pretty lazy and be like, I don't have to go to work, you put me on vacation. This is what's called Cushing's syndrome. This is a patient who has maybe long-term corticosteroid therapy. I'm telling you that she walks around Walmart all the time. You can see this person. Please don't go pull up her shirt to see the abdominal stretch marks, okay? But again, you'll see these patients, they just look very cushy. You'll see them all the time. The more you look around, the more you'll be like, I feel like that patient's probably got something wrong with her immune system. Other analgesics that we can use for patients, there's two of them, the adjunct analgesics, pregabalin and gabapentin. So gabapentin is, these medications work off of the concept of GABA. So here's what we know. GABA is an inhibitory neurotransmitter. It's in your brain, and it blocks or inhibits certain brain signals and decreases the activity of your nervous system, okay? So these two medications affect GABA. When GABA kind of attaches to the protein in your brain, known as the GABA receptor, it produces a calming effect. And it helps with feelings of anxiety and stress and fear, and it calms the nerves down, and it also helps to prevent seizures because it just kind of makes everything go, okay? So these two medications work with GABA, okay? So it's interesting that with the pregabalin, it kind of inhibits the neurotransmitter like substance, the substance P that we talked about in the beginning of the lecture. So with this medication, what's happened is even though it's not a controlled substance, it does not affect your opioid receptors in your brain. What we find with this medication is that it does have a high abuse potential. The pregabalin, also known as Lyrica, actually got moved to a scheduled medication within the last 2 years because of its abuse potential. These medications can cause a bit of euphoria and make you feel a little loopy, and so because of that, we don't want our patients drinking, driving, or operating heavy machinery. We also don't want them drinking alcohol or taking other medications that may interact with them. The most important words you'll ever say to a patient whose pain you're trying to get under control: do not drive or operate heavy machinery while taking this medication. Do not consume alcohol or any other illicit drugs. Do you hear me? Say it with me.